Ectomy means removal of. Oriphy, O-R-R-H-A-P-H-Y, means repair of. Ectomy is removal of synovial fluid, that's where the inflammation is. Oriphy is repair of. So sometimes they can manipulate that synovial fluid. Of course, we can always do a joint replacement if it's severe enough, things like that. Non-pharmacological treatments for those, we can do ice packs, hot packs. We can do plasmapheresis, we do a plasma exchange, take the inflamed plasma out, put some new stuff in. Nutrition therapy, there are some herbs that work great. Again, what's your response if I say, you know what, I'm gonna quit taking my B-Mard, and I'm just gonna start taking an herb instead? What is your response to me as my nurse? Cool. Yes. You know what? Herb therapy works for some people, and some of it's very, very effective for these disorders. True. But you need to talk to your healthcare provider before you switch out meds for your herb therapy, because that's a statement. We don't ever say, "Oh my gosh, I would never go to that practice. Get rid of that stuff, load it up." Or, "Doesn't take all that stuff. You're taking your meds." You need to talk to your healthcare providers. We can do a good analysis as to make sure they don't counteract each other and see what's going to be workable. If you say you want to take this herb, so you maybe take off of your meds. Make sure they don't counteract each other. So that's your statement as the nurse. There are some great herbs. That's where a lot of our drugs came from to begin with, were from herbs, and I think that certainly being open to that as a nurse is appropriate. Because it is effective for some patients, and it's got some less side effects, and we could be here all day talking about that. Your patient is going in for a surgery, and what herbs increase the risk of bleeding? You're going to have him hold. St. John's wort. What? Aspirin. NSAIDs. Or the G herbs. Ginger. Garlic. Ginkgo biloba. All of those. Ginseng. All of those increase your risk of bleeding. So that could be a situation we give to you, the NCREST could give you anytime. What herbs cause increased risk of bleeding? It says that little G list. Ginseng, ginkgo biloba, ginger, garlic, aspirin, as you said, NSAIDs. So you're reviewing your patient's medication profile. He's heading in for a synovectomy surgery. There you go. You're going to have him hold which medications. Could you pick them off a list if you needed to? Questions about rheumatoid arthritis. Given the fact that we have 23 or so questions for most important to know, for all these disorders, ask yourself, where is the inflammation for that disorder? So how I know how this one may be different than the next one, Medication usage, and anything specific that we pointed out when we were talking about that disorder.
So wait, why are we holding those?
What? Because they cause increased risk of bleeding.
So if you have rheumatoid arthritis, you just don't take those at all, basically.
Pardon me?
So if you have rheumatoid arthritis, you don't take those at all?
No, before surgery.
You only take them before surgery. If you're going to have something that's going to cause increased risk of bleeding, I'm going to look at your medication profile and say, you're heading into surgery, today's Wednesday, you're heading to surgery on Friday, you need to not take your NSAID that you're taking for your arthritis. You can't take your aspirin for the next 2 days. Making sure that you're the nurse, you're not going to increase his risk of bleeding heading into a surgery coming up. Questions about that? Look at his herbs, because sometimes they say, I don't take any medications, and you find out they've got lots and lots of herbs that they take. That includes medications, that includes herbs, that includes supplements, things like that. They want the whole thing. Help your family members make a list somewhere besides those pieces of scrap paper that they carry in their wallet. Because we see them like, oh my gosh, A, I can't read that writing, and B, it's been to watch. On my dad's phone, I put as a contact medication list on his phone. I just put it, set up a contact, called it medication list, and I listed all of his meds in his notes there and his doses. I thought, well then, ever in an accident, ever have to go somewhere and not pulling out his paper out of his pocket, that it's on his phone. Just some ideas for you to help people out in your life. My sister calls that OCD. I don't think it's OCD. Fine. Okay, on to lupus. Females more than males, surprise, surprise, not really. Lots of risk factors. Again, autoimmune, body attacks itself, antigen causes an antibody response, self-attack. Butterfly rash is a hallmark symptom of lupus. Looks like it did on this girl right here. You can have rashes other places. Sores. Butterfly rash is a hallmark symptom. I should have put this in red down here at the bottom. Fever is a primary sign of exacerbation. Fever is a primary sign of exacerbation of lupus. These are disorders you don't get rid of. They're lifetime autoimmune disorders. Doesn't mean that you're going to be disabled. Doesn't mean you're going to die an early death. It just means that it's a fact. Then progressive involvement of other body systems, as most of these go and do. Again, medications do great. Patients stay very mobile. It doesn't mean that you're going to have body system involvement at some point in time. It just depends on how well it's managed and controlled. ANA, positive with over 95% of patients with lupus. Oh my gosh, I'm so sorry. You guys just couldn't be. Positive anti-DNA. Again, there'll be a little criteria sheet to figure out for sure which disorder you might be experiencing. You don't need to know these criteria, just know it exists. I know it's frustrating, you're trying to get an absolute diagnosis because you've had these problems with your joints for a while now. That's just not how it goes with these. It's not like heart disease or something else. No CAT scan can just pinpoint exactly what you have going on. And a lot of times just by studies that have been done in the past, we just have to just plug it into a criteria sheet where you might have this or you might have that, and then we just keep working with it until we figure it out. And really, sometimes it matters, sometimes it doesn't. It's going to be sometimes the same medication protocol, and it doesn't really matter always if it's something specific that I can drill down. It's exactly what you have going on. No live vaccines for the reasons we already talked about, right? We're going to suppress your immune system anyways. We don't want you introducing something that might cause you to have an additional disease. We already went through that slide. Same thing as we talked about with our little cover sheet of meds. Those are appropriate for this disorder as well. Additional teaching about corticosteroids. I would probably look at this slide. These are the teaching I'm going to give to you about that. I'd like you to take your medication early in the morning. It'll be most effective then. Stay away from direct sunlight, including UV lighting. Bone density test while you're taking your corticosteroids. Unless knowing that you're at risk for causing bone issues, why don't you go ahead and start taking some kind of calcium every day as well. Questions about corticosteroid teaching? Good question.
Yeah, this is vitamin D and like the natural exposing yourself to sunlight,
Correct. You want you to stay out of the sun. So we need you to take vitamins that would do what sunlight normally does. Correct. Thank you for asking that. Questions about lupus? Okay, Sjogren's. With Sjogren's, the inflammation is in the carotid glands with a P, not in your carotid vessels. Carotid, and they're located right there, right here.
that isn't like a BP face, like sort of a stroke.
No. That's just where the inflammation is. That's where the pain will No, droopy face is some of that's more like Bell's palsy and some of those, which we'll get to when we talk about cranial nerve involvement in neuro. But ask yourself, where's the inflammation, so you kind of can concentrate your thoughts about where the symptoms might be more. With Sjogren's, because it affects the parotid glands are responsible for some of your salivary fluids. So if you have problems, inflammation of your parotid glands, you're gonna have dry mucous membranes. That's what goes with Sjogren's. Is dry mouth, dry nose, because your parotid glands are what's responsible for you keeping those things moist. And when you have inflammation there, if you've got Sjogren's, that's where you're gonna have trouble. That's gonna be the primary presenting symptoms with Sjogren's. Dry mouth, dry eyes, dry mucous membranes. Dry mouth cavities. Yeah. Oh wow, that's right. Think about that, what that will do for your nutrition intake. Again, what symptoms do they present with? You start to drill down about what disorder you might be experiencing. Rheumatoid factor, again, is oftentimes present with Sjogren's. This is a little easier to pinpoint because of the inflammation is specific to the parotid glands. The symptoms are much different than the other joint symptoms and things that we've been talking about. And really, honestly, a lot of times it's just management of the dry mucous membranes is what we're dealing with for that. You know, because it's not joint issues, so it's a lot different than when we're managing your joint problems. So managing dry mucous membranes, oral rinses, no irritating foods, obviously, if your mouth looks like that one did a few slides ago, artificial tears. So Sjogren's is in the inflammations in the parotid glands. Again, when you read a diagnosis, I would try to think to yourself, where's the inflammation? Is it in the synovial fluid? Is it in the parotid glands? So that'll help you pinpoint a little bit more what's going on with that patient. Yes. And nutritionary losses and imbalances, because think about trying to eat and your mouth look like that. Correct. Okay, scleroderma. Sclero means hardening. Like we talked about atherosclerosis, right? Hardening, and derma means skin. Women more than men, middle age. We don't really understand the pathophysiology here as well. What goes with scleroderma, this is an important slide to know. What goes with scleroderma is what we call the CREST syndrome, C-R-E-S-T issues. Scleroderma is the only disorder that we have talked about thus far that has a C in the name. So CREST syndrome goes with scleroderma. If that helps you kind of put those two together. Calcium deposits, Raynaud's, esophageal dysmotility, sclerodactyly, and that word I can't pronounce means spider-like hemangioma. Usually it starts with Raynaud's, part of that. So scleroderma, C-R-E-S-T syndrome, R being Raynaud's. Guess where I studied Raynaud's?
Yeah.
What teaching goes with Raynaud's?
Cold hands and feet.
Okay, cold hands and feet. What do you teach me about that? So we didn't do that when I have Raynaud's.
Something more, gloves.
Wear gloves when you're taking stuff out of the freezer, when the freezer's back in the grocery store. Pardon? Vasodilation medications to get more blood circulation there, protect those fingertips. Frostbite, wear gloves in the wintertime, all of those pieces. Because the R part of CREST that goes with scleroderma is Raynaud's. Because it's hardening of the skin, break that word down, they end up having stiff joints, Stiff movement, including their facial movements. So you see that mask-like appearance, hardening of the skin, including all kinds of skin, including their face. It progresses, causing complications, causing problems with swallowing. Sometimes they have autoamputation, where their fingertips fall off on their own.
Oh my goodness.
Yeah. Hardening of all their body systems. So think about that when the lungs become hardened. That's typically the cause of death. Again, very seldom can we do some magical diagnostic test to figure out what you have going on. What does an EKG study? Heart. What is an EEG study?
Brain.
Brain. What is an EMG study? What is the M part of that? Myelo, which is muscles. So an EMG is appropriate for all of these patients, right? Not an EKG, not an EVD, not an whatever else they all are. EMG, the M part is myelo muscles. So it's appropriate for a lot of these patients that we're going to do an EMG today, figure out what kind of muscle movement you have or don't have, and that's another diagnostic test that you would want to prescribe for lots of these patients if they present with muscle stiffness, right? So EMG is a good one to put maybe on your cover sheet for any of these. That might be an appropriate med diagnostic test. Just break the word down. So you told me about managing his Raynaud's because that was the R part of this, right? What's esophageal dysmotility? What does that mean? What does DYS means? Difficult. Motility is movement. So you're gonna have problems with swallowing.
Swallow.
What interventions do you want to prescribe for that? Swallow steady, but now swallow steady is real. Indeed, you have difficulty swallowing. What kind of patient do you want to give to me? Diet changes. Tell me what that means.
Thicken
Okay,
stuff.
soft foods. What kind of other interventions when you're taking care of this patient? Okay, stitch you up. Exactly. So all those principles you already know. But certainly is appropriate for you to give thought to when your patient presents with scleroderma. Let me think what that he has. He has CREST. I probably can't. Which way is his calcium level going to be when you do that blood test? Up. Correct. So I'm going to expect elevated calcium levels. I'm going to teach and manage his Raynaud's phenomenon as in protecting his digits, right? I'm going to help him. I know that the E part of that is he has trouble swallowing. I'm going to sit him up. Soft foods, small bites, chew carefully, all those things that you do when you are feeding perhaps a 2-year-old. And I probably can't do much with the rest of those, but could you spell out and tell me what CREST means? But you certainly can do something with his Raynaud's. You certainly can help assist with his esophageal dysmotility. Again, very few conclusive tests. We can give you a calcium channel blocker to improve your Raynaud's. Exactly what we talked about here. We want to vasodilate, get you some more blood flow to those digits. We can oftentimes prescribe some kind of Prilosec, some kind of medication to help with your esophageal dysmotility, your GI reflux, which occurs because your food doesn't go down and stay down the way that it's supposed to. Again, we can't change the fact that you have the disorder. We can certainly manage your symptoms and improve your quality of life in the meanwhile. We can try to improve your smooth muscle movements, diagnosis as you can imagine, impaired skin integrity, impaired circulation. Hallmark symptoms of scleroderma are the ones that go with crest. The leading cause of death is when the autoimmune issues start to attack the respiratory system. Questions about scleroderma? Your patient, so when you start taking your test questions, when when the patient presents with scleroderma, pause for a bit and just ask yourself, okay, what is that? Or where's the inflammation? What do I know that goes with that? Before you cruise to the rest of your question. That's my best advice to pause and process. So your patient presents with scleroderma. Okay, let me think about that a little bit. That's crest. I'm gonna write out C-R-E-S-T on my paper, my scratch paper. I'm gonna give thought to that for just a second, and then I'm gonna cruise to the rest of the questions. And it'll be about something we just talked about in the last 5 minutes, for sure. That's my best advice. What is a hallmark symptom, or what are you thinking is gonna go with this patient's situation? Formulate it in your brain, pause the process before you start cruising through your answers. So we don't talk you to picking something that's not the right answer. That's my advice for all of these. Okay, rheumatoid arthritis. Where's the inflammation? Synovial fluid. I'm gonna think about that. It's in the synovial fluid, so it's typical joint pain. That's not too unusual. Something that's unusual that goes with this one is a synovectomy, right? Because that's where the inflammation is. Or a different situation, your patient comes with Sjogren's. Let me think. The inflammation there is in the parotid gland, so therefore I know he's gonna have what symptoms? Saliva and mucous membrane symptoms. That's what I would recommend for you for next week. Pause and think what we just did in your brain for just a few seconds of time, and then write it out if you need to. So it's all clear in your head, and 90% of the time you're gonna know exactly where that question is gonna go. Okay, I have a couple more to go, and then we'll. Poly means many, multiple, correct? Myo means muscle, itis means inflammation, there you go. Like I said, there's lots and lots of them. We spent more time on the primary ones just now. Some of these we're going to cruise through pretty rapidly. I can give you a use of NSAIDs, use of a corticosteroid for any of these, and you still know how to answer that kind of type of situation. Multiple muscles involvement, autoimmune. Again, muscle weakness, muscle tenderness. What is myalgia? Algia means pain. And then myo we said was muscle. Again, EMGs are always a good diagnostic that we can use for lots of these patients. We can always muscle biopsy these patients to see for sure what's going on within that muscle. Those meds we already talked about. You know, teaching is where your corticosteroids is. Don't ever stop taking them cold turkey, right? You always want to reduce your dose, reduce your dose, reduce your dose. So even if that means helping your patient find out a schedule. Because those little pill bottles have it all written out on there like that sometimes. Take 3 pills today for the next 3 days, take 2 pills the next 3 days. Like, oh my gosh, I'm going to expect anybody to fill it. You know what, I'll just write that out. Today is Monday. So take 3 today, I'm going to write you a little table. Tomorrow's Tuesday. Thursday, I'm going to write down, take 2 tablets. Friday, take 2 tablets. Saturday, take 1 tablet. Because it's hard always to comprehend what the nurse is telling you. The more you can print out and give to that person, the better off they'll be when they have to get home and can process it, especially when they have a family member sometimes that's trying to help them, and they're like, what did she say, or what did he say to do? I don't know. It was busy and it's loud. Well, it's written right here. It's printed right here. I'll make you out a schedule of that, exactly how to take your pills. Fill your pill organizer. This is week 1. I'm going to write that marker on the back. This is week 2. Put it with your coffee cup in the morning. This is corticosteroid, take it in the morning. So put it with your coffee cup. Put it with something you do in the morning. You don't forget to take it. Just put a cup of water right here next to it. All those things can help your patient be more compliant. Especially when you're sending them home in a hurry and you're giving them all kinds of discharge instructions, and then they get home and they're like, I don't even know what that was overwhelming. Even if they're a nurse, they're in the medical field, you make no assumptions. Because you all get specialized, you'll be really great at your specialty, but you won't have studied scleroderma since this week. Like, I don't even know what that is. So, I know you're a nurse, I know you've been a nurse for a long time, but I'm going to give you the same education as I give everybody else that has scleroderma. Because then, A, you're not feeling stupid when you ask the question. I should know this, but I don't. And then you're getting treated the same. If you need me to skip any of this, because you already know this, just let me know. But otherwise, I'm going to treat you exactly the same as I do that one, that one, that one. Because that's what's only fair. Just because you're a nurse doesn't mean you're gonna remember all of this stuff, especially when it's your own diagnosis now that you're dealing with. When I had my first baby, I worked with that nurse. She gave me my discharge instructions and she said, well, you're a nurse. And she didn't go over anything. And she left the room and I'm like, yeah, I'm a nurse. I've never done OB, never had a desire ever to do OB. I've never had a baby before and I know nothing about what this is. I don't have any recall what that even means. And I thought, oh, this is too bad because then I felt stupid saying, I don't really know any of that. I don't know what to expect. I don't know how to do any of this stuff. So A, I felt stupid, and B, there was a presumption on that nurse's part that I knew this stuff. It's a new diagnosis for me, a new thing that I've never experienced, and I'm gonna treat you exactly the same, even though I know you're a nurse. I think that's the fair thing to do. And if you already know it, well, good for you. It just reinforces what you already know. It's different when it's your own diagnosis. Assist with ADLs always. Are you guys good if we go one last diagnosis and then we go to lunch? Poly means many, muscles. These are grouped in the same category. Again, the pathophysiology here is that it's inflammation of the vessels that affect the arteries for these two. Now, the inflammation is in the blood vessels. You know, sometimes we had them in the joints, we had them in the glands. Now they're in the blood vessels for PMR and GCA. When you go home tonight, you go, oh, we said all about PMR and GCA and EMGs. Really refresh your memory. Inflammation in the arteries. Multiple areas of pain, but look where the inflammation is for the GSA or the GCA. It's right there in his temporal arteries, right here.
Wow.
So ask yourself, where's the inflammation? It's not necessarily a muscle disease as much as it is a vessel inflammation, vessel disease. Same concepts, inflammation is still an autoimmune disorder. It'll present as muscle discomfort, but when we start to do biopsies, diagnostic tests, that's where the inflammation is in the vessels. In red and bold, because you know with GCA, his inflammation is in his temporal, when he tells you he has a loss of vision, or blurred vision, or a headache, that should be a big red flag for you. Because that could be pressing up against his optic nerve, which is located right here as well. So because the inflammation is in his vessels, in his temple, in his head, you're worried about his optic nerve involvement. So that's the patient teaching that will go with your patient. Because your inflammation is in your vessel right here, which is really close to your optic nerve, the first time that you experience a significant headache, blurred vision, change in your vision, I need you to contact a healthcare provider immediately. Because your worry is pressing on his optic nerve. Ask yourself, where's the inflammation? Again, diagnosis is difficult. We can do some inflammatory tests. We can biopsy those vessels. We can do a temporal artery biopsy if we're thinking that's what he's got going on, that GCA there. Of course, risk involved with that always when you're messing with that. Same medications as we've been discussing. Monitoring for optic nerve involvement when we're talking about GCA. Questions about that one?
Hang on, I have to clarify. PMR is muscle. It's in the muscle in GCA.
The inflammation for both of these is in the vessels.
Is GCA in the?
In the vessel, but it happens to be in this vessel right here.
And PMR is in the vessel as well? Or?
Yes, it is. It affects the arteries. The inflammation is in the vessels, as in the medium-sized and large arteries. That's where the inflammation is for both of those.
Medium and large.
I'm going to turn this off. I'm so sorry. This is supposed to be all I do. So much. Yes, but with this inflammation, it's in the arteries, which makes it different than some of the ones we've been discussing, right? Which makes this, both of these, a little bit unique to that effect. And GCA, the biggest concern you have is knowing it's in the inflammation's in the arteries, and that artery happens to be located right here for GCA. That's your biggest concern as a nurse. But it's weird, it's in the vessels, but it happens to be for PMR, it happens to be the vessels that are located in the core area of the body. It's just the way it's designed. Questions about those two? After lunch, we'll start talking about osteoarthritis, gout, some other ones included. I got some sample complex questions that we'll just kind of hit on when we get on with the day today. At 11:33. And we'll start back up at 12:33.